There's a lot of discussion in terms of who's eligible for FLOT, and if a patient's eligible for surgery, then they're eligible for FLOT, but I think this can be a discussion point because I would disagree with that. We talk about this all the time in the context of we don't want to make patients too sick to get to surgery. I think we've all had experience with FLOT where the tolerability of that regimen, particularly in an elderly patient, can make patients too sick to perhaps even get to an operation. So I think these are all reasonable approaches to treatment.
I think a lot of it is eyeball test. Are they walking into your clinic? Are they in a wheelchair? But whether they can get surgery or not, that definitely plays a huge role. If the surgeons are comfortable taking them to the OR, then we at least try to give FLOT. Actually, I think we've gotten a lot more comfortable using FLOT even in patients with questionable performance statuses. And then we just have really low threshold to de-escalate from FLOT, as opposed to, I think, just a few years ago, what we've been doing was just go straight to full Fox and not even try FLOT. But
yeah. I think that's. I agree that that's a very reasonable approach and very common. I feel that the data to support perioperative doublet chemotherapy is not so strong. It's really just the adjuvant K-pox data with Classic.
Right.
So a lot of people that I talk to in the in the community in particular, they feel more comfortable doing Taxol carbo and radiation for the people that aren't eligible for FLOT. I think I'm hearing more and more that people are doing reduced dose FLOT and then just dropping, the Taxotere or something like that pretty quickly. Dr. Iqbal, what do you do?
I either do reduced dose FLOT or full Fox if I feel that I'm going to hurt the patient with upfront. And again, sometimes I'll even start with full Fox and see if they tolerated it, and then add the dose of Taxol with the second cycle.